We sort of have this very simplified understanding of obesity. People living with obesity are stigmatized and sort of blamed for their condition, and it's sort of not really widely understood to be a disease. But there's a lot of science behind it. What's your sort of take on the science of what causes obesity?
Andrew, thank you for bringing this up. A great campaign has been going on changing the language of addressing obesity. There is a lot of work going on into the obesity stigma. But I agree with you, we're missing the science. And I think it's easy to miss the science because obesity is a very complex disease, a multifactorial disease driven by many different parameters. But I think the key molecule, and you agree with me, I think, is leptin. So leptin resistance is probably the biggest driver of the obesity pandemic and the effect it has in the signaling between the gut, the brain, and the adipose tissue. And this leptin resistance is fueling insulin resistance and further weight gain and suppression of the gut peptide hormones. And this is, I think, the main driver, along with genetic and epigenetic changes.
Yeah, I mean, I think probably just to clarify what leptin resistance is. Leptin is a hormone that's produced by the fat cells, and it's supposed to act as a signal to your weight control center in your brain, the hypothalamus, to tell your brain how much fat you've got on board, how much energy you've got on board. The problem is when that stops working, the leptin signal gets blocked by insulin, but also inflammation. What's your take on inflammation and obesity? Is it an inflammatory disease?
Very good point. So the adipose tissue releases more than leptin. It releases pro-inflammatory cytokines as well. So I think, as we know, obesity is associated, linked to chronic low degree of inflammation. And that's in part due to the release of pro-inflammatory cytokines like TNF-alpha. But I think the food choices in today's society may be influencing this.
So obesity itself causes inflammation, but actually some of the foods that we eat, some of the processed foods also cause inflammation. And the more fast food and processed foods we have, the more the ratio of two essential fatty acids in our diet, omega-3 and omega-6, they balance each other on a ratio, depending on the intake in your diet. And they are essential fatty acids. So the omega-6 coats every cell in our bodies. And when you get a preponderance of it compared to omega-3, that affects insulin signaling in itself. So, by having a Western diet, not only taking in refined carbohydrates, which are going to cause insulin, but also taking in too much fast food, vegetable oil containing food, you are profoundly affecting all of your cells in your body, so insulin doesn't work properly. Again, getting you into this massive vicious cycle of too much insulin in the body, blocking leptin, and then these signals and the symptoms of the disease, starvation, feeling of hunger, and lassitude. When we have a Western diet, we have a lot of omega-6, which is inflammatory. So the diet itself, the Western diet, fast food and processed food and food that sits on a shelf is pro-inflammatory. So that combined with the fact that obesity itself is an inflammatory condition, these two things block leptin and, the signal doesn't get through. So you have a situation where a patient is with high leptin levels, but because of the inflammation, the diet, and the insulin, that signal's not getting through. We know that obesity causes type 2 diabetes. What effect does that have on insulin signaling? Do you need more insulin with type 2 diabetes?
Yes, it is a vicious circle. Overeating doesn't cause obesity. It is actually obesity that causes overeating because of all the mechanisms you explained. So early in the onset of diabetes, the beta cell, the organs producing insulin, the pancreas, are preserved. Their function is preserved. But over time, that deteriorates. At some point, insulin is inevitable. But then again, more insulin fuels more resistance to insulin, and that fuels more hunger and more weight gain. So it is a vicious cycle. And nowadays, a lot of patients with uncontrolled diabetes need to have bariatric surgery in order to improve their cardiometabolic health and also improve their health through weight loss. We have a multidisciplinary approach to managing patients with obesity. What is your view on that? Are there benefits to treating patients with different treatments? Obviously trying to tailor treatment, but different modalities, like blocking different pathways?
Well, I'm going to defer the medical treatment to you in a minute, because I know there's a lot of new, really exciting treatments coming out that are actually quite effective. I'll talk about bariatric surgery in a second, but I think if we understand obesity, just as we've explained it, it is a condition caused by the type of food that we're consuming, not particularly the calories, but actually that food does to your body. If we understand that, then actually by encouraging people at a very early stage of obesity or overweight not to go on diet, the problem is a lot of people don't learn how to cook. So they're at the mercy of, our big supermarkets with all the processed foods in the middle of them. So that would be my advice for someone struggling with overweight. Don't go on a diet. Going back to our weight set point theory, when you do, for instance, gastric bypass, their weight set point is here. Overnight, their weight set point has gone back down to close to the normal range, but they're finding the signals are pulling them actually to just being slightly overweight. And it's a really nice feeling for them. They totally feel in control. I'm sure you've seen them before.
Yes.
What about the medical treatment of obesity?
So I like combining treatments to treat obesity, and we try to do that in our unit. I know other units do the same. So I think the manipulation of gut hormones is the main medical modality. And this originates from the outcomes of bariatric surgeries. We're living in the era in which the physicians are very privileged to have the options of treating patients with other than advice. So I think the main treatment options are GLP-1 receptor agonists, which, as you know, by giving them supraphysiological doses of what is essentially missing, as we described earlier, we are helping them improve their satiety, increase their satiety, or reduce their hunger. But there are other options, there are different options, and blocking one pathway is not really the way forward. There's no one right answer to treating obesity. So we have different treatments, dual agonists, ghrelin enzyme inhibitors, other treatments, GIP, PYY analogs, and also we have oxyntomodulin analogs and other medical treatments. But I think the key message is that we need to tailor treatment. We need to combine treatments to get the most out of the treatments we have.
Yeah, I mean, I think the whole change in the understanding of obesity comes from this realization that actually the stomach and the intestines are what we would call an endocrine organ,
yes,
as well as a digestive organ. What we didn't understand until recently was that the intestine and the stomach produces these hormones that change our behavior, and also the fat, going back to leptin. So I think it's fascinating that you guys now are being able to prescribe particularly one hormone, GLP-1, which mimics, that hormone going from your intestine, which sort of appears about half an hour after eating, which is supposed to be the signal for you to stop eating to your brain. But actually we can give that by injection under the skin, and it stops that, that pullback of voracious appetite when you lose weight. So
yes,
I think that they're great treatments.
Since we have been speaking about leptin resistance and leptin being the main driver, what is your view on replacing leptin? Is that a viable pathway moving forward? Can we give leptin because of the resistance to leptin?
So, I mean, that's a fascinating subject. And as you probably know, years ago when leptin was discovered, I think there was a pair of sisters who were leptin absent, so there was no leptin signal. Mm-hmm. When the scientists then gave them leptin, their weight normalized. And this was like, we've got it, we've cracked obesity. But then actually when the scientists gave leptin to people who don't have a natural leptin deficiency, but just have obesity, they've already got a lot of leptin in the system. So to give them more didn't work because the leptin's being blocked. So, it was quite an exciting time in obesity research, but that's before we realized leptin was important and, crucial in weight regulation, but that's before we understood leptin resistance. So, George, a lot of people will say that obesity is linked with food addiction and the fact that our highly processed foods are really, really tasty and people get addicted to them.
This addiction is driven by biology rather than by choices. We go back to what we have been discussing all day today. So it's going back to the adipose tissue and the gut, the effects of leptin and resistance to leptin, the effects of gut hormones to appetite regulator, the hypothalamus, and the fact that these patients have blunted signals when it comes to appetite and satiety. So they feel hungrier, they tend to overeat, and that fuels further overeating. So obesity drives this process?
Yeah, I think I agree that once you've developed leptin resistance, so obesity caused by leptin resistance, the behavioral signals from your hormones will give you this voracious appetite. And you have that voracious appetite, that's, hormonal behavior that's, imprinted in you in an environment where the food industry produce food that people really want to buy and go back to. So we know that, for instance, sugar has the same signaling pathway actually as an opiate drug, so it gives you a similar reward to a much lesser dose, but it does give you a similar reward when you have sugar. It's like a drug. So I think that there is a degree of perceived addictive behavior. These people are ravenously hungry because they're leptin resistant, which is the biology of obesity, and you have hedonic food around you. So it's almost preordained that you're going to become a bit addicted to that.
If the right choices are made with regards to their diet and their lifestyle, are we solving everyone's problem with doing that?
If you are just overweight and want to lose some pounds, I think if you follow really good lifestyle changes, learn how to cook, eat 2 or 3 healthy meals a day, and over time, maybe over a couple of years, your weight would settle down, or your weight set point would settle down towards normal weight. However, those people who are suffering with more severe obesity, even if you have those great lifestyle changes, the leptin resistance is going to stay there to a degree. It doesn't matter how hard you try and get out of that, it's still going to be there. And this is where this group of patients suffering with proper obesity benefit from bariatric surgery. And it's such a powerful tool, to change the way the guts are configured, and that therefore then changes the signals from the guts to the brain to give this, seamless satiety, lack of appetite, normal metabolism, and your weight set point just automatically decreases towards a healthy level. So I do think there is a fairly large subset of people suffering with significant obesity who, even with lifestyle changes, they need more. I think for people suffering just with obesity throughout their lives, just increasing throughout the years and decades, their weight, bariatric surgery is a really good option. The 2 main operations that we're doing are the gastric bypass and the sleeve gastrectomy, and both of those really affect that signal from the stomach and guts to the brain. There's another old-fashioned or older-fashioned operation called the gastric band, which is basically like a sort of plastic-type ring with an inner tube that you can tighten that is above the top of the stomach. Now, that produces weight loss basically by stopping you eating fast. But the problem with that is, as you lose weight, it doesn't change those signals.
So, Andrew, we've spoken a lot about the etiology of obesity, the complexity of the disease and the management. We haven't spoken a lot really about another metabolic disease, which is closely linked to obesity, type 2 diabetes, which, as you know, is another pandemic. So a modality that is used more often nowadays is metabolic surgery to treat type 2 diabetes. Some of these patients achieve remission of diabetes, though without weight loss. So what is your view on the weight loss independent metabolic benefits of having bariatric surgery?
I think that's a good question. And yeah, we do see people who have type 2 diabetes. So unlike type 1 diabetes, where there's a shortage of insulin, actually early type 2 diabetes, there's too much insulin. And actually that's why that then blocks leptin and you get this vicious circle of obesity and type 2 diabetes. The really good thing about the gastric bypass in particular is that as food goes from ingested food, it goes through a small little stomach pouch, and then through that it goes straight into the intestine. So within 5 minutes of eating, food is in the intestine, which is the small intestine, which what the body perceives that to be you've overeaten. So it produces this hormone that's supposed to stop you eating, GLP-1, but also it actually has a effect on insulin function. So it improves significantly the sensitivity or the effectiveness of insulin. So overnight, you'll see some people who maybe they've been diagnosed with type 2 diabetes over the last 2-3 years. You do a gastric bypass, and suddenly they don't need any treatment. The diabetes has gone straight into remission because GLP-1, because of this, change in the plumbing of the intestines, has increased significantly, caused insulin to be much more effective again and reverse the diabetes. And the great knock-on of that as well, obviously, you don't need as much insulin to work. So certainly the leptin signal is getting seen because the obscuring insulin has gone away. And GLP-1 also is a satiety hormone, so you don't feel hungry. So all of these things just nail your weight set point much further towards normality.
Obesity is a complex multifactorial disease requiring multimodal approach to ensure better outcomes. It is a relapsing disease, so patients need to be educated on the long-term changes required even after bariatric surgery. Metabolic surgery is a very effective way to treat type 2 diabetes by improving the signaling of insulin, leptin, gut peptide, hormone release, improving satiety, and therefore causing weight loss as well.
So I think the take-home points from this episode are the fact that obesity is caused by leptin resistance. Leptin is the hormone that comes from the fat that's supposed to signal to us, how much energy we have on board, and that gets blocked by insulin and inflammation. High insulin levels come from the Western diet, sugar and refined carbohydrates. Inflammation comes with obesity itself, but also is contributed to again by fast food and processed foods with the omega-6 in there. And this all causes this cascade of the leptin signal not being read, and the fact that metabolic surgery is actually really good to deal with this. What are your takes on it, George?
I think the takeaway messages are that leptin resistance is a key driver. It hampers insulin release and insulin sensitivity and the effects of insulin centrally, but also the release of gut peptide hormones, and thus causing obesity along with the Western diet. I would say that metabolic surgery is a key modality to treat type 2 diabetes mellitus, primarily when it's early onset and not complicated. Education around obesity as a disease is missing. Healthcare professionals should increase their awareness of obesity as a disease and the complexity involving etiology and management.
I think to understand obesity appropriately, we need to get away from that simplified energy in, energy out equation as the primary cause of obesity and think much more along the lines of what processed and westernized foods actually do to our bodies to encourage it to gain weight. In a way, obesity is an appropriate response to a Western diet.
Lifestyle interventions have been unsuccessful previously and currently in maintaining metabolic health.
So you mean that the more you diet, the more difficult it becomes to lose weight, the more efficient your metabolism is, the more you rebound back up. So I think we have a much better understanding of weight regulation now, how our weight is regulated really by leptin, and how signals from hormones in our stomach and guts, GLP-1, PYY, ghrelin, signal how much energy to take in, and then leptin itself, acting on our metabolism, signal how much energy to expend. And this usually keeps us on an even balance until we get to this problem with leptin resistance, which causes obesity.
Genetic, epigenetic, and environmental changes bind us to the weighted endpoint and predetermine our response to different modalities and the effect these will have on coexisting complications of obesity. We are living in the era of tailored medicine, and within the NHS we have scarce resources to treat patients with obesity. So finding the right treatment for the right patient at the right time is key to optimizing benefits and outcomes to patients with obesity. Predetermining response to treatment through the use of multiomics, mRNAs, exosomes is key to determine response and outcomes. Multimodal approach is key for ensuring best possible outcomes for our patients. Obesity.
The big truth.